TNOA Connect series on ocular trauma in conjunction with Joseph Eye Hospital, which is the gold standard eye hospital as far as Tamil Nadu education is concerned. Very happy to be associated with Joseph Eye Hospital. I had my training there also when I was in Shankar Netralaya. It's always a pleasure to have all of you on board. And today I am in also a TraumaCon conference of the OTSI, Ocular Trauma Society of India in Gwalior. That's the reason why I'm not able to get this thing, but very soon after my presentation, I'll be joining the webinar. I'm looking forward to a great webinar, and over to our dynamic secretary, Dr. Madhavan, to say a few words, and then followed by Sriram Gopal and Nehru, and then we can start off.
Thank you, dear President. Respected President, Dr. Mohan sir, the elite panelists, our wonderful past President, Dr. V.M. Loganathan sir, moderator, coordinator, and our elite panel of speakers, members of TNOA who are tuned in, both in Facebook and watching this eighth month of activity since September 2021, when our president took over as the president of TNOA. We have been having the ARC, PG Catalyst programs, the Connect series, the Walk the Talk series, and many more. TNOA is shining for the past 8 months under the able leadership and dynamic leadership of our President, Dr. Mohan Rajan. Today, we are indeed honored to have Connect series with Joseph Eye Hospital in the series of Consolidate, Coordinate, and Trichy being the Mecca of Tamil Nadu Ophthalmic Association. Trichy, where it all began so many decades ago. And today, TNOA is 6,500 members strong organization. One thing is very important. Thanks to the initiation from the Trichy Association so many decades back. And today, TNOA is a gold standard of ophthalmic association throughout our country. Next August, we'll be having our 69th state conference at Coimbatore, and we will be having our Tamil Nadu Ophthalmic Association elections as well, which will be for the first time an online election. I request all our members to update the data for our association activities. We have been sending pro forma in both by post, by WhatsApp, and also email, so that members can update their details, so that it will help us smooth conduct of our association activities. In similar vein, next month we are having AOS conference at Mumbai, and before that, the AOS elections for the vice president are also being slated to be held. And we all know that our president, Dr. Mohan Rajan, will be contesting for the post of vice president AOS. And we know all these activities that has taken place in Tamil Nadu, if extrapolated in a larger canvas of the nation, it'll be a great activity for ophthalmology nationwide as well. So I request all our members to enthusiastically participate, motivate others to participate in this electoral process, so that our dreams could be realized in the next 1 month. And thank you for this opportunity. Looking forward to a wonderful webinar on ocular trauma today. Thank you for the opportunity. Dr. Sriram.
Good morning, everybody. Wishing everybody a wonderful day here. It's indeed a present privilege to be a part of this webinar today. And as President Dr. Mohan Rajan and our Secretary Dr. Madhavan has said, nothing is left for me to say. I would like to welcome our President, our dear Secretary, and our teacher, Dr. VMS sir. And we have an array of specialists distinguished in their own specialities to talk of ocular trauma today. And I don't think I should keep you waiting anymore. Let's enjoy the webinar. Deepak, over to you.
Thank you, sir. Good morning, everyone, and a very warm welcome on behalf of Joseph I Hospital. I am Deepak Artha, and I will be your moderator for today. And on behalf of all the management and staff of Joseph I Hospital, it gives us great pleasure to conduct today's TNOA Connect webinar series in association with the TNOA. So I would like to thank all the office bearers, especially the President, Dr. Mohan Rajan, for giving us this wonderful opportunity to host today's session. In today's webinar, we will be systematically going through the various aspects of ocular trauma, and we hope that it would be beneficial both to residents in training and to practicing ophthalmologists. We have eminent speakers to take us through this 2-hour rapid fire round of ocular trauma. So I would just be introducing today's panelists. Can you please allow Dr. Harini to share her screen? The PowerPoint is on her laptop. The first panelist for today would be Dr. V.M. Loganathan. He is one of the most senior members of the TNOA. He did his undergraduation from Madurai Medical College and his post-graduation there as well. He served in the army for the past, for the period of 5 years as captain, and he has also done his vitreoretinal fellowship from Cambridge. He's worked in several government medical colleges and has also been the project director of the Tamil Nadu Blindness Control Society. And he's also a recipient of several prestigious awards, including the Joseph Nyanadikam Oration Award, the C.S. Reshmi Award, and the Lifetime Achievement from the award from the TNOA. And he's currently Professor Emeritus from at Joseph I Hospital. So we welcome Dr. Loganathan to be a part of the panel. The next panelist would be Dr. Sudarshan Seshasai from Singapore. He has done his undergraduation from the Yong Lulin School of Medicine and has completed his Master of Medicine in Ophthalmology. He is at present a consultant, associate consultant at the Singapore National Eye Center. And he's actively involved in training and education of undergraduate and technical staff at Singapore. He's also recently been awarded the Singapore Health Quality Service Gold Award in 2022 for his exemplary services in medical care. So he has numerous publications in peer-reviewed journals. We welcome you, sir, to be a part of this academic session. The next panelist would be Dr. M. Pratibha. She did her undergraduation from Tanjavur Medical College and post-graduation from Joseph I Hospital and her MPhil from BITS Pilani. She is at present the director and medical superintendent of Joseph I Hospital, Trichy. She is an active cataract surgeon involved in retina and retinopathy of prematurity, and also an NABH assessor, recipient of several prestigious awards. Okay, that's okay. And the fourth panelist for today would be Dr. Sujata. She is also a part of Joseph I Hospital. She heads the glaucoma department. She did her undergraduation from Lady Harding Medical College, New Delhi, and her post-graduation from AIIMS, Delhi. She's actively involved in glaucoma and cataract surgeries. She has more than 50 presentations in national and international conferences and several publication in international journals. So thank you, panelists, for being a part of this session and to help us moderate this 2-hour program of trauma. So I would like to go on to invite the first speaker for today's session. The first session, we would like to give you an introduction of the different nomenclature and classifications of ocular trauma. I would like to invite Dr. C.G. Vanila to talk to us about this. She did her undergraduation from Madras Medical College and a post-graduation from Madurai Medical College. At present, she is a professor in the retina department in Joseph I Hospital and also heads the paramedical courses over here. She's a recipient of several prestigious awards, including the Professor E.T. Selvam Quiz Gold Medal in '98 and the Professor C.P. Gupta Best Paper Award in 2012. She's an excellent teacher and a quiz master. I would like to welcome Madam to come and deliver her speech. Welcome, ma'am. Over to Dr. Vanila.
Good morning. Good morning, everyone. At the outset, I would like to thank TNOA to giving me this wonderful opportunity I'm not able to share my screen. Can you help me?
Yeah, even I was not able to share my screen. Can you please change the settings for that?
It is just said host disabled participant screen sharing.
Doctors, can you try now?
Okay.
Deepak, sharing is fine now, I think.
One minute.
Vanda ma'am, I think they have enabled the share screen option now. Can you please try sharing it now?
Yeah.
Madam, meanwhile, you're working on two devices. On one of the device, you will have to remove yourself from the audio so that the echo is not going to happen.
Okay.
Yes, ma'am, your slides are visible now.
Okay. Thank you for this opportunity. I'll go straight to the topic. Sorry for the delay. My topic is nomenclature and classification of ocular trauma. Ocular trauma classification group was convened in the year 1997. And they developed the Birmingham Eye Trauma Terminology System, that is called the BETS, in 2004. And these group analyzed 100 variables of over 2,500 eye injuries, and then they came out with the ocular trauma score, which is used to predict the visual outcome of patients after open globe ocular trauma. This Birmingham Eye Trauma Terminology System classified the eye injuries into a closed globe and an open globe. The closed globe injuries are further classified into a contusion or a lamellar laceration. The open globe, we have laceration and a rupture. In the laceration, we can have a penetrating trauma with the intraocular foreign body or a perforating. The terminologies which should be known are the eye wall. What is the eye wall? It's outer core of the eye, that is the sclera of the cornea. A closed globe injury is the one where the eye wall does not have a full thickness wound, whereas an open globe injury has a full thickness wound. The closed globe injuries are again classified into, according to the 4 parameters. First is a type of injury, whether it is A is contusion, B is lamellar laceration, C is a superficial foreign body, and D is mixture of these. And the next parameter is the grade. It is according to the visual acuity. A is above 20/40. B is 20/50 to 20/100. C is 19/100 to 5/200. D is 4/200 to light perception. E is without light perception or no PL. Pupil again is graded into positive or negative. If positive, the RAPD is present. B if it is RAPD negative. Then there are zones for closed globe injury. The zone 1 is the injury involving the conjunctiva, sclera, and cornea. Zone 2 is injury to structures in the anterior chamber, including the lens and zonules. Zone 3 is the posterior segment structure injury, including the vitreous, retina, optic nerve, choroid, or the ciliary body. The examples for closed globe injury, you can see to my left is a dislocated lens in the anterior chamber, an iris injury like a iridodialysis. Here is a subtotal and total height femur. And it can be mixture of all this, like what I said. There is subconjunctival hemorrhage, which is a contusion. You have a blood clots in AC. You have traumatic cataracts, sphincter tears. Or it can be just a white eyeball with a blunt trauma causing a beautiful rosette cataract. Open globe injuries, again, they use the same 4 parameters. First is a type, from A to E. A is rupture of the globe. B is penetrating trauma. C is with intraocular foreign body. D is a perforating injury. And E is mixture of these. The grade is the same. Better by 20/40 is A. No light perception is E. And between visual acuities are graded B, C, D. Pupil again, if there's APD, that is positive. If it is negative, RAPD is not there. Zones, there's a difference between closed globe and open globe. In open globe, zone 1 involves only the cornea. There's a penetrating trauma. Zone 2, anterior 5 millimeters of the sclera is also involved. Zone 3 is the injury involves the sclera, which extends more than 5 millimeters from the limbus. So we'll come to each terminology now. First, rupture is an open globe injury where there's a full thickness wound of the eyeball, that is either the cornea or the sclera, usually caused by a blunt object. The impact results from momentary increase in the IOP, and it will be caused by inside-out mechanism. Laceration, on the other hand, is a full thickness wound of the eyeball. It is caused by a sharp object. The wound occurs at the impact site itself, and it's an outside-in mechanism. And the lacerating injuries can be a partial thickness or a full thickness laceration. So this is laceration, a lamellar laceration, self-sealed wound in the cornea with the cataract. This is a penetrating injury. That is a single laceration of the eyeball caused by a sharp object. You can see here the corneal, full thickness corneal tear with the iris prolapse and the total height femur there. And if it is retained with the intraocular foreign body, then you can call it, you can categorize under the IOP. You can see the entrance laceration here with the embedded foreign body. This is a metallic foreign body with the blood clots on the iris. This is a perforating injury. Here you have 2 full thickness lacerations of the eyeball. One is the entrance wound, next is the exit wound. It is usually caused by a sharp object or high velocity objects like a missile. Previously, prior to the beds, we were using blunt trauma and penetrating trauma. This often led to confusion because a blunt trauma can cause a confusion like this or an rupture globe of an open globe injury like this. That's why beds have come into a terminology right now. In this picture, you can see the globe of the left eye is almost intact and you can see a laceration just medial to the medial canthus of the lacrimal sac area. In this patient, there was a foreign body which was lodged in the orbit between the medial rectus and the medial wall of the orbit, and it was removed by a medial orbitotomy. So this is not coming under any classification of your Birmingham eye trauma trial. So they proposed a new classification. This is the new proposed classification of ocular trauma, which was given by Shukla and all in the year 2016. And they classified according to this into a local, that is only the eye is injured, or it is associational with other parts of the body, or where is the cause of the injury, where the environment at which the trauma has been taken place. So local can be classified again into mechanical and non-mechanical. In the mechanical group, we have whether it is a global injury or an adnexal injury. In the adnexal, we have the orbital, palpebral, lacrimal or conjunctival injuries. In the global, we have according to the structure, we can subclassify it, or according to the pathology, we can classify it. The structure, we can classify it according to the anterior segment involvement or a posterior segment involvement. The anterior segment, whether it is corneal injury, scleral, uveal, lens, or the pupillary involvement, we can classify. Posterior segment like vitreous, retina, choroid, scleral, or papillary. Papillary is the optic nerve avulsion, all those things come under those injuries. The pathological classification is this, what we already see, closed globe injury, open globe. Here they have introduced one terminology called destructive globe injuries. The closed globe, whatever I said earlier, contusion and lamellar laceration. Also, they have included the extraorbital foreign bodies, intramural foreign bodies, and dislocation. In the open globe injury is the same as the Birmingham's eye trauma terminology, rupture, penetration, perforation, and intraocular foreign bodies. In destructive eye injuries, you have traumatic evisceration, enucleation, and full thickness laceration, more than 1/3 of globe circumference. In the non-mechanical, we have other injuries like chemical injuries, thermal injuries, radiational hazards, electrical injuries, ultrasonic and barometric injuries. These barometric injuries are common of the blast injuries seen in the warfare. So this is the local classification. Next is associational. Associational means it is associated with head injury, so visual pathway is compromised, or with face injury, so orbital injury is more common, or with multiple injury, multiple fracture along with eye injuries. And next is environmental, the place of injury, whether it is during birth, congenital, in the industry, it is industrial, recreational or sports related, or in the travel, during a travel, you have an RTA in which eye can get injured, criminal activities like assault, and agricultural activities and casual activities like pen or something in the home activities daily activities leading to eye injuries. So this is the classification which is proposed at the recent terminologies used. And they also subclassified the ocular foreign bodies into global, adnexal, and mixed. And you can have in global, whether it is intraglobal or extraglobal or intramural. Intraglobal is within the eye, extraglobal is outside the eye, intramural is within the coats of the eye wall, that is the cornea sclera. Adnexal is either orbital, palpebral, lacrimal, or conjunctival, and these are subclassified according to the location, whether they are in the anterior chamber, lens, vitreous, choroid, retinas, actively. Mixed is, it can be either in the globe or in the adnexa or both. So these are some examples I want to share with you. Intraglobal corneal foreign body with the entrance laceration. The picture to your right is a wooden foreign body in the anterior chamber. This is an intracanalicular foreign body, so it's a extra global foreign body. This is a intraretinal foreign body. It's in the retina, so intraocular foreign body. And they devise the ocular trauma score to grade the visual prognosis even after 6 months of the open globe injury. This is computed on these factors shown here. First is the initial raw score. This is calculated on the initial visual acuity the patient presents with. If there is no PL, it is 60 points. If it is PL to hand movement 70, 1 by 200 to 19 by 200, it is 80. 20 by 200 to 20 by 50, it is 90. Better than 20 by 40 is 100. And if the injury is associated with globe rupture, you have to deduct minus 23. With endophthalmitis, it is minus 17. Perforating injury, it is minus 14. RD is minus 11. RAPD is minus 10. So you sum up all this to get the raw score sum. Once you get the score, you can categorize from 1 to 5. 0 to 44 is grade 1, 45 to 65 2, 66 to 80 is 3, up to 91 is 4, better than 92 to 100 is 5. Why they graded like this is to alert the visual prognosis and tell about the patients. So if the lower the score, the worse the prognosis. So no PL can be around 73% if the score is in the category 1. But if it is in the category 5, there are no patients with no perception of light. And after 6 months, 92% of these patients will have a vision better than 20 by 40. These are the predictions given by the ocular trauma score. So this is to summarize of how the ocular trauma score works up with the initial visual acuity presentation and the major serious injuries to the globe. That is all in the nomenclature. Thank you so much for your patient listening.
Thank you, madam, for that beautiful presentation. Thank you for highlighting about the older classification and the newer proposed classification as well. Any other comments from the panelists regarding this?
Once again, thank you for the kind invitation. I feel very privileged and humbled by the presence of many distinguished professors here and the president, Dr. Rajan. So just to share, I mean, it was a very good presentation by Dr. Vanilla. Thanks again for sharing with us the new and the old classification. Maybe from because I only exited recently, so I'm in tune with some of the exam questions. So usually for this mainly for the junior residents, what the classifications and the scoring would come out for the exams. Mainly they would ask about the difference between rupture and also laceration. Rupture is where it's burst open, laceration is where it's slicing. And the next one was they would also ask about the difference between penetrating and perforating. I think this was also explained by Dr. Manila just now, where there is a entry and exit wound in the perforation injuries, and there's only one wound, entry wound for the penetrating injury. So, and also one other thing that it could add here is that this is an ocular emergency. So unlike other injuries, these patients with ocular trauma, it's essential to see them early. And the main thing is also to rule out any life and sight-threatening conditions first, and after which we would try to repair the globe to ensure the integrity of the globe, remove any foreign bodies, and then treat any infection. But it's actually a very good lecture and presentation on the classification. This is something I'd like to share. Thank you.
Thank you, sir, for your comments. And if we do not have any more comments, can we go on to the next presentation?
Yes, I'm muted.
Next, I would like to call upon Dr. Harini Karthik to share her screen. She would be talking about injuries of the lid and lacrimal system. Dr. Harini Karthik did her undergraduation from the postgraduate Pondicherry Institute of Medical Sciences and her post-graduation from Joseph Eye Hospital, Trichy. She did her fellowship in orbit and oculoplasty from Aravind Eye Hospital, Madurai, and at present the assistant professor at the Department of Orbit at Joseph Eye Hospital. She's an active oculoplastic and cataract surgeon and specializes in surgeries of the lid and lacrimal system. I would like to welcome Dr. Harini for her presentation. Over to Dr. Harini.
Good morning, one and all. Am I audible? Is my screen visible? No? Is my screen visible? My slides visible?
Your video is visible.
Okay.
Deepak, slides have not started yet, Deepak.
I don't know, it's not opening.
Madam, can you stop sharing and share it again?
Stop sharing. Okay. Yeah, share again. Yes. Okay. Okay. Now am I visible?
Yeah, please go ahead and just move to the full screen mode, actually, presentation mode. It is in the slides after.
Okay. Good morning, one and all. At the outset, I would like to thank the organizers of TNOA for giving me this opportunity. It's a privilege indeed to share this platform and to be speaking in front of all my teachers. And thank you once again, TNOA. Today, my topic will be on injuries of the lid and the lacrimal system. I'll be dealing with the lid injuries first. So, eyelid lacerations, partial thickness and full thickness defects are a significant subset of facial trauma. It is often accompanied with other facial injuries, an injury to the globe, cornea, and the lacrimal system. A few words about the relevant clinical anatomy. So as we all know that the lid consists of an anterior lamina and a posterior lamina. Sorry?
Only your intro slide is on. Yeah.
Yes, it's seen now? Okay.
Deepak,
Alright.
it's not in the presentation mode.
The clinical anatomy of the lid consists of two lamina, the anterior lamina and the posterior lamina. The anterior lamina is composed of the skin and the orbicularis, and the posterior lamina composed of the tarsus and the conjunctiva. Cut section of the lid showing the anterior lamina and the posterior lamina. The three important structures to remember here is the line which is formed by the meibomian gland orifices, which lies inside the tarsal plate. Just anterior to the meibomian gland orifices line is the gray line, and little more anteriorly is the lash line. These three are important structures to remember when we come to injury of the lid. I'll be dealing with it later. The picture on the right shows the anatomy of the levator palpebrae superioris. We can see that it is inserted into the upper superior 2 to 3 millimeter of the upper tarsus. Just in front of the levator palpebrae superioris is the orbital septum and the pre-aponeurotic pad of it. Moving on to the etiology of the lid injuries. The mechanism of lid injury can be either a sorry for the technical glitch.
Some presentation here. It's okay, just carry on. Carry on.
No, without the screen. One moment.
Yes, ma'am. Right, slide control.
Okay, moving on to the etiology of the lid injuries. Mechanism, it could be because of a contact with a sharp object moving with a high velocity, or it could be from a avulsion from a blunt trauma. The most common risk factors being male because of men, because they are exposed to workplace injury, children and young adults, environmental exposures like having pets at home or stray dogs, sport injuries or workplace injuries. Moving on to the goals of the eyelid repair. I think my screen is not visible.
Madam, if you can just send us the presentation, we can run it on your behalf.
We're done. Yeah,
Same thing only, but I think multiple things are being opened. So no. Stop share.
the screen share is fast. Yeah.
All right. Sorry for the delay. The goals of the eyelid repair. The goals of the eyelid repair are to restore the anatomical configuration and thereby improving the function, and at last to improve the aesthetics of the person, thereby improving his self-confidence. Depending upon the timing of surgery, it can be done as a primary repair, which is usually done within 24 to 48 hours of the injury. A delayed primary repair is when we sort of control the edema and the infection because of the injury per se, and delay the repair, primary repair, by 3 to 5 days. The secondary repair is usually resolved to major lid reconstructions, which can be done after 6 months. So the things to remember in any injury is to classify it into a simple injury, lid injury, or a complex lid injury. To classify it whether it's a partial thickness or a full thickness, as the name indicates, a full thickness if it involves most of the lamina, anterior and the posterior lamina. If it is marginal or an extra marginal, if there is a canalicular involvement or not, if there is a canthal injury or not. So the picture in the first shows a lower lid, full thickness, marginal laceration with the canalicular involvement, but without the canthal involvement. The second picture shows a partial thickness laceration. A few words on wound healing. Wound healing can be of two types, primary intention and a secondary intention. Primary intention is when the wound edges are opposed and the wound is allowed to heal at the same time all across. Healing by secondary intention is when the wound is allowed to granulate and heal from the base to the surface. Aim of a surgery in any lid repair is to obliterate the dead space, thereby approximating the wound edge, thereby creating a fine scar as much as possible. So few things to remember in wound healing is the tension lines across the face. If the wound lies in line with the tension lines in the face, then the wound just has to be gently approximated. However, if the wound lies across the tension lines of the face, then the skin edges have to be everted to compensate for the contraction of the wound. Here there is a partial thickness laceration, as we can see, but it lies along the tension lines of the face, so it can be just gently approximated without much of pressure, thereby causing eversion. The general principles of wound repair. As to any injury, the first most important thing is to stabilize the patient, the airway, breathing, and circulation. Next most important step is to rule out possible intracranial, spinal injury, intraorbital, any globe injury. And usually the timing is within 12 to 24 hours of the injury, but it can be delayed, as I already said. It can be delayed up to a few days, thereby controlling the infection and allowing the edema to settle, and then we can proceed with the primary repair. And the choice of anesthesia is generally the surgeon's choice, general anesthesia or local anesthesia. Generally in children and patients who are not comfortable with the local anesthesia, if there is a bicanalicular involvement, we would prefer to do a general anesthesia. And always to look for a foreign body. The most important thing of a lid correction is to improve careful alignment of the anatomy, the lid margin, the lash line, and the skin folds. Never to excise or discard the tissues because it might be very vital. And the lid laceration should always be closed in layers, and any major reconstruction can be delayed after 6 months. So in detail about the full thickness defect, usually the full thickness defect is closed in 2 layers. The first suture is the lid margin suture, which is placed at the line of the meibomian implant orifices, as we can see in picture A. The second step is a partial thickness tarsal suture. Here care is to be taken so that it does not involve a full thickness tarsus, so that the sutures do not abrade the cornea. It has to be a partial thickness suturing. The next step is the gray line suture and then the lash line suture, followed by the skin suturing. In detail about the lid margin suture, which is usually a vertical mattress suture. The picture here shows the point of entry and the point of exit are at equidistant from the wound margin. Easier way to remember is a far, near suture, it's commonly said. And usually the upper lid injuries, the formula to remember is a 5335. And in lower lid injuries, it is 3113. That is where the point of entry and the point of exit. We can see here how a slight eversion is caused because of the vertical mattress suture. This is again to show where to start and where to end in a vertical mattress suture. Starting point is here at the far end, at equidistant from the wound margin. It's on the other side, and similarly far, and then comes to C and D near. This is how a vertical mattress suturing is done. Based on the tissue loss, depending upon the horizontal extent of the defect, the injuries can be of three types. Small defects are when it is less than 1/3 of the lid is involved. Medium defects are 1/3 to half of the lid involved, and large defects are more than half. The small defects can be closed by primary closure, or in case if it is not possible, we can always do a lateral canthotomy and cantholysis. Inferior cantholysis in case of lower lid injuries and the superior cantholysis in upper lid injuries. The management of a medium defects and large defects is usually done by flaps, which are beyond the scope of today's talk. I'll be limiting myself to the small defects, which is less than 1/3. These are a few examples of how a full thickness lid tear suturing was done. A pre-op, as we can see, it's almost full thickness lid tear. The tarsus is involved. This is the patient after suturing. This is the post-op image. This is again a complex lid tear, full thickness tarsal involvement. This is the post-op image of the patient. So repair of the small defects of less than 1/3 of the horizontal length can be done by direct closure. So I've already mentioned, if direct closure is not possible, a lateral canthotomy and cantholysis to help to mobilize the lid tissues can be done. Few words about the canthal tendon injuries. Canthal tendon injuries deserve a special mention because most of the times it is missed, and failure to repair of a canthal tendon injury can result in a disfiguration. So medial canthal injuries are often associated with canalicular injuries. We have to remember that if only the anterior limb of the medial canthal tendon is involved, it is rarely necessary to repair. However, if the posterior limb is injured, then it has to be fixated based on the points available. This is a picture of a patient with the anterior limb of the medial canthal injured. Here I have opposed the medial end of the tarsus to the medial canthal tendon after exposing it. This is a post-op image of the patient. However, if the posterior limb of the medial canthal tendon is involved, it has to be the medial end of the tarsal plate has to be anchored to the periosteum behind the lacrimal sac, which is usually done with a non-absorbable Prolene suture. Special mention about the injury to the levator palpebris superioris. High index of suspicion should be kept whenever a patient presents with a orbital fat exposed in a levator injury. There is a high probability that the levator is injured if the orbital pad of fat is exposed, and it should be repaired at the time of closure, and it should be reattached to the tarsal plate. Traumatic ptosis caused by blunt trauma, it's preferable to wait till 6 months to do any surgical correction. A special mention on dog bite injury. Usually is most common in young children. 75% of the injury occurs in children less than 9 years of age, and it is very commonly associated with canalicular injury. Most important thing to remember is that the soft tissue infections is very common because there are multiple organisms, both aerobic and anaerobic, in the saliva of the animal. So it is very common to have a soft tissue involvement. Earlier, it was thought that to leave the wound without a primary repair, but now the current system is to do a forceful thorough irrigation with saline, then do a betadine povidone iodine irrigation. A judicial debridement, taken care not to involve most of the, just a careful debridement. And local anti-rabies immunoglobulin is advised as a post-exposure prophylaxis at the wound site. In an early wound closure, along with the canalicular repair is advised. Prophylactic systemic antibiotics, both aerobic and anaerobic control should be given. And patient should be taking anti-rabies vaccination along with immunoglobulin and a tetanus toxoid. If possible, not possible in our setup, but if possible, the vaccination status of the dog to be noted. These are a few points to remember in the dog bite injuries. Moving on to the nasolacrimal system injury. Isolated nasolacrimal system injuries can occur, or it can occur concurrent with the orbital and facial injuries. The most canalicular lacerations happen along with the midfacial fractures like LeFo 2 and 3 fractures or naso-orbital ethmoidal fractures. And among the canalicular lacerations, the lower canaliculus is most common, and the specific mechanism of injury is often a blouse hook injury. Based on the etiology of the lacrimal drainage system, it has been classified by work in Art Berry. It is divided into mechanical classification, if it is only penetration, or it can be avulsion. Iatrogenic can be accidental during orbital surgery, extensive retraction of the wound, or it could be thermal or chemical, or it could be intentional, as in management of dry eye or patient awaiting a cataract surgery, we do a punctal cautery. It can be intentional also. Thermal injuries, chemical injuries like vitreolage or chemotherapeutic agents like 5-fluorouracil application, or it could be radiation, external beam radiotherapy induced damage. The clinical assessment, it is always wise to remember that the lower canaliculus is most commonly involved, followed by the upper canaliculus, followed by bicanalicular involvement, followed by nasolacrimal duct, lacrimal sac, and the lacrimal puncta. This is the order in which it is involved. It is a general principle that lid lacerations, any laceration medial to the puncta will have a canalicular involvement unless proven otherwise. In patients with suspected maxillofacial trauma, a CT orbit is mandatory to rule out a bony nasolacrimal duct disruption. And if a fracture repair is planned, it is wise to do a lacrimal irrigation prior to the fracture repair. As in any management, the advanced trauma life support, ABCDE, to be followed first to rule out any intracranial cervical globe injury prior to suturing. Identifying the canalicular injury. Mostly, it is a difficulty faced by the new oculoplastic surgeons or residents who are suturing. It is to identify the canalicular injury. So there are a few tips which we can help. First thing is the examination of the medial end of the upper lid and the lower lid under high magnification. This is the typical calamari sign, as the arrow is pointing, which shows a white collagenous ring which is surrounded by blood-stained tissue. The other options available are the Morrison's method, in which air is forced into the other opposite canaliculus, and we can see bubbles coming out through the symptom, through which we can identify the canaliculus. The other methods are fluorescein stain syringing through the opposite punctum. A pigtail probe was also used earlier days, but now it is frequently avoided because it has a potential to damage the uninvolved canaliculus. It has to be remembered that patients can also present with a late diagnosis. It usually happens in patients with mid-phase injury or trauma to the naso-orbital ethmoidal. Initially, patients will be asymptomatic, but can later present with epiphora. Lacrimal irrigation and a probing is must for such patients. This is a picture showing how to identify the end of the canaliculus. This we can see the calamari sign here. The white collagenous rings around it in the area of blood-stained tissues. The way of confirmation is to pass a probe into it. This is the Bowman's probe being passed through the upper punctum, which we can see is coming out through the cut end of the canaliculus. The role of imaging in the diagnosis is that when the midfacial injuries or the naso-orbital ethmoidal fractures are there, CT orbit is a must to rule out injury to the bony nasolacrimal duct and to the injury to the lacrimal fossa as well. It can sometimes be caused post-operatively, especially in patients who have undergone mid-phase injury fractures, who've been repaired. ORIF is done, open reduction internal fixation is done. Sometimes the plates and screws may be in way of the injury, so that it may cause a secondary nasolacrimal duct obstruction. Such patients will usually present with a late onset tearing. So management of canalicular repair, early repair is always better than late. There is a query regarding whether monocanalicular injuries should be repaired or not. Earlier, it was thought that upper canalicular injuries can be left alone because the upper canaliculus constitutes only about 25 to 30% of the tear drainage. But the current management protocol says that irrespective of whether it's an upper canalicular or a lower canalicular injury, any monocanalicular injury has to be intubated, has to be repaired. Canalicular injuries are best done within 24 to 48 hours, but it can be delayed as to 4 to 5 days. If there is a bicanalicular involvement, bicanalicular stents are usually placed, which needs a general anesthesia. The duration of stenting again is controversial. Generally, it is now it has been said that 6 weeks is the minimal time for which the stenting has to be placed, unless the patient is symptomatic. These are the steps of management of a canalicular injury. Here is a probe is being passed through the cut end of the canaliculus. We can see through coming out through the cut end. The distal end of the canaliculus is identified and the probe is passed through the distal end until we get a hard stop. This is a mini monocast stent which has been placed, brought out through the cut end and passed through the distal end of the canaliculus. Pericanaliculus tooth string is then placed and the litte repair is proceeded as described earlier. Coming to the intubation systems, there are two ways, bicanalicular and a monocanalicular intubation. Bicanalicular, the most commonly used stents are the Crawford, Ritling, and the stent tube. And the monocanalicular stents which are most commonly used are the Monoca, Mini Monoca, and the Crawford Monoca. In cases where none of these stents are available, people have always also used Venflon catheters for the management of canalicular trauma. The advantages of a bicanalicular stent is the ease of the use. It is less expensive when compared to the monocanalicular stent. But the difficulties are, it is done under general anesthesia. There is a potential theoretical risk of injury to the other canaliculus. And the removal of the bicanalicular system is relatively hard. The advantages of the monocanalicular system is it can be used in only one canaliculus is involved. The removal is easy and it is done under local anesthesia. However, the disadvantages are that it is difficult to identify the distal end. And even though pericanalicular suturing is done, it is easy to get lost. And the cost of the monocanalicular stent is relatively high. This is a picture showing a bicanalicular Crawford stent compared to mini monoca stent, monocanalicular stent. This is a picture where when stents are not available in peripheral setups, Venflon cannula is being used to manage the canalicular repair. This is a 24 gauge Venflon which is being used. Moving on to the tube related complications, the most common complication is in a bicanalicular stent is the prolapsed bicanalicular stent. It is just minimally prolapsed. It can always be repositioned. But however, if it has been fully prolapsed in coming out through it, then it may require early removal. And when opposed to the monocanalicular stent, the most common tube complication is the stent loss or stent migration. Sometimes there can be punctal cheese wiring, as we can see in this picture. This is due to excessive manipulation and the sutures are being tied too tightly, then it can result in punctal cheese wiring. Sometimes there can be a pyogenic granuloma associated. In such cases, we might have to remove the stent earlier and the granuloma has to be excised. Despite these things, persistent epiphora can happen despite stenting. Moving on to the nasolacrimal duct injuries. The bony fracture of the nasolacrimal duct injuries is most commonly associated with the facial trauma. 7 to 15% of patients who have facial trauma have associated bony nasolacrimal duct injury. It is prudent to consider a duct rhinostomy or a CDCR at a later stage. However, things to remember are such secondary nasolacrimal duct injuries or secondary to trauma have a higher failure rates, which may be because a patient might have already had multiple episodes of chronic dacryocystitis, or there might be interference from the reconstruction or the plates or screws. All these things are predisposing to the high failure rates. However, adjuvants like mitomycin C and intubation can increase the success rate to approximately 92% in such cases. In mid-phase injuries or injuries to the nasoorbital ethmoid is suspected, it is prudent to always take a CT orbit. And if the CT orbit shows just a minimal disruption of the lacrimal fragments, only a conservative care is sufficient. But if there is a gross disruption of CT prior to manipulation, prior to surgery, prior to ORIF, it is wise to do a prophylactic intubation to leave the intubation tube for 3 to 6 months before proceeding with the surgery. In the absence of a canaliclar injury, extended dacocysterinostomy is still a gold standard. Thank you.
Okay, thank you, Dr. Harini, for that beautiful presentation. Any comments from the panelists? Okay, if there are no comments, we can move on to our next presentation. I would like to call upon Dr. Tendral Ponnudurai. She did her undergraduation from Tanjavur Medical College and a post-graduation from Joseph I Hospital. She's at present an associate professor in the cornea department at Joseph I Hospital, and she specializes in refractive and corneal surgeries and keratoplasty. She is a cataract surgeon as well. I would like to welcome Dr. Tendral to talk about mechanical and chemical injuries of the anterior segment. Over to Dr. Tendral.
Good morning, everyone. I thank all the TNOA organizing secretary and members for giving me this opportunity to present in front of my teachers. I'll be talking about mechanical and chemical injuries. Injuries to the eye can be classified mainly as mechanical and non-mechanical injuries. Mechanical injuries again can cause trauma to the globe or to the adnexa. The non-mechanical injuries are caused by chemical, thermal, radiational, and electrical hazards. Coming to mechanical eye injuries, it is broadly classified as open globe and closed globe injuries. Open globe again can be divided into globe rupture, where there is increased pressure within the eye causing a full thickness wound. Or it can be a laceration, which again is classified into penetrating, perforating, and an intraocular foreign body. And closed globe injury is where there is no full thickness eyeball wound. It is again classified into contusion, lamellar laceration, and a superficial foreign body. I'll be mainly concentrating about chemical injuries of the eye. It is an acute ophthalmic emergency which requires immediate management to prevent or minimizing devastating sequelae. For all ocular injuries, it constitutes about 11.5 to 22%. And mostly young males are affected. And it is interesting to note that children of 1 to 2 years are particularly at high risk. The most common acids which cause ocular chemical injuries are sulfuric acid from the car batteries, and other acids are sulfurous acid, hydrochloric acid, hydrofluoric, and acetic acid. Coming to alkalis, we commonly encounter line injuries from the whitewash. And other alkalis causing injuries are potassium hydroxide from caustic soda, magnesium hydroxide from crackers and fireworks, ammonia, and sodium hydroxide, which is also called as lye, which is found in drain cleaners. Pathophysiology differs in acids and alkalis. Acids cause coagulative necrosis, and where the tissue surface proteins are sacrificed, and the resulting coagulum, it prevents the further penetration of the acids. Whereas in alkalis, they cause a liquefactive necrosis. This saponifies the fatty acids in the cell membrane, which causes the cell death. And further penetration is possible in alkalis. 2/3 of chemical injuries are caused by alkalis. Roper Hall grading system, there are 4 grades in Roper Hall grading. The first grade is there is only epithelial damage, there is no limbal ischemia, and the prognosis is very good. The second grade is where there is a corneal haze and iris details are visible, and around only 1/3 of limbal ischemia is there, less than 1/3. And this also has a very good prognosis. The grade 3, there's a stromal haze and iris details are very hazy, and limbal ischemia is more than 1/3 to about half. This carries a guarded prognosis. The grade 4 is a total opaque cornea where more than half of the limbus is ischemic, and this carries a poor prognosis. In DOAS classification, the Roper Hall grade 4 is again divided into 3 more grades. So totally we have 6 grades, and it depends on the clock hours of the limbal ischemia. The grade 3 is more than 3 to 6 clock hours. Grade 4 is more than 6 to 9 clock hours. Grade 5 is more than 9 and less than 12. And in grade 6 is very poor. All 12 clock hours of the limbus is involved. Management strategies includes all these 3. The epithelial reconstruction, the control of inflammation, and prevention of complications. All this has to be done simultaneously. For epithelial reconstruction, a copious use of lubricants is advised, along with doxycycline tablets, and vitamin C. Vitamin C can be used as tablets or as eye drops, and autologous serum has also been tried. For control of inflammation, corticosteroids has been used. We can use dexamethasone or a fluoromethalone. For prevention of complications, broad spectrum antibiotics, preferably preservative-free, and IOP has to be monitored regularly, and use of cycloplegics is advocated. In the emergency room, the patient is positioned with their head well supported and with the kidney tray on the side, and the affected eye has to be irrigated. The copious irrigation has to be done for at least 15 to 30 minutes. It can be done with a balanced salt solution or a ringalactate solution. And then the patient has to be evaluated in the slit lamp, and the severity has to be assessed. This has to be mandatorily done. This is a double eversion of the lid with a Desmarais lid retractor. Usually the foreign body lime particles will be lodged in the fornix. Coming to grade 1 management, the copious irrigation has to be done for at least 50 to 30 minutes, and a double eversion of lids, and epithelial reconstruction has to be done with lubricants. Topical steroids has to be started on day 1, and slowly it has to be tapered, and within 2 weeks it has to be stopped. And regular monitoring of IOP is needed. All the for grade 2, all the emergency treatment, as previously mentioned, has to be done, and the patient has to be definitely referred to a cornea specialist. And IOP has to be monitored. Suppose the IOP is high, we can start on beta blockers or oral acetazolamide, and a broad spectrum antibiotics, preservative free, has to be started, along with cycloplegics for pain reduction and Seneca formation. Grade 2 usually carries a good prognosis. To grade 3 management, all the above management, along with a frequent follow-up visits and monitoring of IOP is needed. This usually will require an amniotic membrane transplantation. I'll be talking about it later. And coming to grade 4, definitely this will go for a surgical management. It will need a limbal stem cell transplant or a keratoplasty in later stages. Coming to surgical management, usually it is advocated for grade 3 to grade 6 DOAS classification. An amniotic membrane or a tenoplasty can be done. This is amniotic membrane. Amniotic membrane comes in 2 varieties. It can be a wet or a dry type. It restores the ocular surface. It promotes epithelialization, and it reduces inflammation and pain. It has growth factors, so it promotes wound healing. It prevents scarring and new vessel formation. A limbal stem cell transplant has to be done wherever there's a limbal stem cell deficiency. It can be partial or a total. When one eye is involved, a conjunctival limbal autograft or a simple limbal epithelial transplantation can be done. where the both eyes are affected and asymmetrically it is involved, then a cultivated limbal epithelial transplantation can be done. Where when it is bilateral and symmetric involvement is there, an allograft either from a living donor or a cadaver transplant can be done. This is a case where the patient had unilateral chemical burns, and after 3 months, we planned for a conjunctival limbal autograft from the other eye. These two are a limbal stem cell transplantation taken from the other eye, and over that, an amniotic membrane was placed. And about 2 months later, the patient regained a vision of 6/24. This is a simple limbal epithelial transplantation. In this, only 2 mm of the limbus is taken. It is a cut here, and this is the affected eye where the planus is dissected. 360-degree peritomy is done. And amniotic membrane graft is placed over this, and the 2 mm stem cells is cut into pieces and kept over the amniotic membrane, and glue is applied. This simple limbal epithelial transplantation combines the advantages of a cultivated limbal epithelial transplantation and a conjunctival limbal autograft. The main point is that it does not sacrifice more than 2 mm of the other eye. Mucosal membrane graft can be done. This is called as cultivated oral mucosal epithelial transplantation. This promotes epithelialization and reduces inflammation. And the eye can be prepared for further keratoplasty. Oral mucosa has similar properties like the conjunctiva. It is easily available and it can be harvested repeatedly. There will be no rejection, and it acts as a scaffold for proliferation of epithelial cells. Keratoplasty can be done where there is visually significant stromal scars or a perforation. It can be done alone, or it can be combined with the amniotic membrane transplant. If a limbal stem cell transplant has been done, keratoplasty has to be done at least 3 months later. Keratoprosthesis can be done where there are multiple failed keratoplasties. A Boston type 1 or a type 2 can be planned. To potentially improve the outcomes of management, anti-VEGF therapy has been tried. Can be given as topical or a supplementable drops, injections, but there are safety concerns. And stem cell therapy has been tried in animal models, which has shown to accelerate the corneal healing and attenuate inflammation and new vessels. Thank you.
Thank you very much, ma'am, for that wonderful presentation, concentrating on chemical injuries. Are there any comments from the panelists?
Again, a very good presentation. One practical thing I'd like to add from my limited experience would be also to look at the eyelashes. Sometimes some chemicals, some cement and all that, they could be in the eyelashes. So it's important to also just look at the eyelashes to clean away any chemicals or any cement particles that could be there. Thank you. But very good, excellent presentation so far.
Doctor, one thing the etiology, the alkali injury, normally the bottom of pocket is very important. When they open it, they get the injury. So this should be either should be abolished, or they should come in a dabba, like as you used to see in those days. That's the only thing left. And I would have been very happy if you could show the limbal ischemia, how exactly limbal, because many of the junior people may not know about it. So limbal ischemia should be highlighted there, which is very, very important, because really many times people get deceived by looking at the cornea is very clear. They think, yeah, very happy, nothing has happened. So the 2 points are very, very important as far as I'm concerned. And they should not be carried away. There's nothing wrong with the patient. And regarding the proper education must be there. They should know how to prevent these injuries. Thank you, Dr. Chandral. It's a nice lecture.
Okay. I think we can move on to the next session. I would like to welcome Dr. Naresh Babu from Aravind Eye Hospital, Madurai. Dr. Naresh did his undergraduation from Kilpauk Medical College and his post-graduation from Jipmer, Pondicherry, and his FNB Vitreoretina from Aravind Eye Hospital, Madurai. He at present heads the retina department at Aravind Eye Hospital. He is also an executive member of the VRSI and has recently been conferred the fellowship by the ASRS as well. He is an expert vitreoretinal surgeon with more than 18 years of teaching experience, and he has several international and national publications, more than 105 academic publications, and he's a regular reviewer of many peer-reviewed international journals. So I would like to welcome Dr. Naresh Babu to talk about management of posterior segment trauma, including intraocular foreign body. Over to you, sir.
Thank you, Deepak. Deepak, just a word of caution. If I'm exceeding my time, just warn me, I'll stop it. Okay?
Okay, sure, sir.
Thank you very much. Okay, so let us start with the ocular trauma. I think a lot has been spoken about ocular trauma, so I'll just skip the introduction. But when a patient comes to us with ocular trauma, there are three windows basically. So they will come in acute window. So the main purpose of the acute window is when the patient comes within 24 hours. The purpose is to restore the integrity of the eyeball and to avoid infection, because these people are very highly prone for infection. But in the next two windows, actually, when they come in chronic and the delayed, they usually present with sequelae. Like in case of a foreign body, there can be infection, there can be vitreous hemorrhage, there can be optic nerve damage, or what do you call it, the retinal detachment. So usually these two windows require the skill of a VR surgeon in case of a posterior segment trauma. So the last window, usually they present with the delayed presentations like cirrhosis. So when a patient comes with the open globe injury or a posterior segment trauma, first thing is you have to look for the systemic stability, because many a times it can be associated with the systemic trauma also. So we have to look for the stability, because in my practice, actually, almost all the posterior segment trauma, if it's an open globe injury, we take under general anesthesia. So it is better to go for a systemic examination, history taking, and as far as possible, make it a MLC, because later on when they come for a certificate, it usually creates a lot of problem. And most of the classification, as discussed earlier, they don't include the ocular, the orbital wall or this thing. So you have to evaluate the periocular trauma. Injection of TT is must. Shield for protection, and usually keep them nil orally so that it is easy for us to take immediately for the under general anesthesia. So these are the things we have to look for: when, who, what, how, and the site of injury. And many times what we miss is the occult tear. Usually in case of a closed globe injury, it happens, especially at the site of insertion of superior oblique. And third thing is the patient on the left side, you can see the patient has got very minimal congestion and subconjunctival hemorrhage, no other symptom. Patient came with 6/6. But whenever the patient comes with a history of injury, always suspect something more. And when we inspected with indirect ophthalmoscopy, you can find a foreign body embedded temporal to the fovea. So if neglected, just treated as a subconjunctival hemorrhage. We have had one case. They will go for the sequelae, including endophthalmitis, landing us in soup actually. So a lot has been spoken about classification, but we talk actually, but most of us, we don't do this classification meticulously. So we have to classify every other injury, and it is very important to classify the injury, because we have to prognosticate the patient. Because the patient's first question will be, when we say we are going to operate, they expect a huge improvement in the vision. So they usually don't understand the reality. So we have to be very brutal in telling the facts and prognosticating the patient before we take them for surgery. Another thing is imaging, which is very important. Any patient, whether it's a closed globe injury or open globe injury, doesn't matter. You go for imaging, especially X-ray, PA view. AP view is not recommended because we'll get a lot of bony shadows. Go for a PA view. Look for foreign bodies because it is important medico-legally, and the rest of the imaging we'll discuss subsequently. As I have told, these are the three basic windows. So when they come with the chronic window, they usually come with what you call the complications. So in case of open globe injury, the immediate management will be corneal and scleral wound repair, because our purpose is to achieve the ocular integrity. And the most important thing is ocular trauma is like if the patient is no PL, usually in other conditions, people will not operate, but no PL, no perception of light is not at all a contraindication for surgery, because many patients, I think close to around 20% without PL will turn at least with PL or hand movements are much better vision following the surgery. A delay in surgical intervention usually leads to very poor visual outcomes. So as far as possible, take it as an emergency. Okay, so this is a flow chart of how we do. So that I'll just skip because that has been discussed. And this is a case of a 46-year-old gentleman who came with a globe perforation following stick injury. And you can see in the CT, you can see the flat tire sign and what do you call ultrasound also showing a flat eyeball. And when this was referred, actually the patient was recommended enucleation, but we wanted to give a chance to the patient. Believe me, we went in for a what you call wound exploration and primary repair, and that was done by one of the colleagues actually. What we did was suturing of the sclera and AC reformation, and this was 1 day or second day post-op. And this patient came after 14th post-op day like this with kissing choroidals and hemorrhagic choroidals. What we did was then we took this patient for surgery actually. So you can find out a 6 mm cannula space. The patient is having an IOL, I think, no, it's aphakic. The vitreous hemorrhage was cleared. You can find temporally there is a hemorrhagic CD. Usually we go for a 2-stage in these cases. 2-stage in the sense like usually I do a complete vitrectomy, inject the eyeball with PFCL, leave them for 4-5 days. And now actually this is the CD is drained with a non-valved 23 gauge cannula. Usually I prefer 25, but 23 is also fine. You can find out the suprachoroidal blood is being drained through the non-valved cannula. During this procedure, raise the intraocular pressure of the eyeball to maybe 60 or around 60. So you can find all the suprachoroidal fluid being drained. Once it is drained, when we go inside, you can find out the CD is completely resolved. And we injected the patient with PFCL, left it for 4-5 days. And this is the second stage of the patient. You can find the PFCL filling, and there is still some nasal suprachoroidal hemorrhage. The PFCL is removed and it is replaced with, you can find out the last bit of the oil and the PFCL being removed, and then it is replaced with oil. And this is the post-op view and the fundus picture. The patient improved to 660. So what I mean to say is if the patient is having a flat tire sign, usually the recommended treatment is what you call the enucleation, but still you give a chance to the patient. There is every chance that the patient will recover the vision, but at the same time take care of the sympathetic ophthalmic otherwise. So these are the references that NPL is not a contraindication, and so the role of a systemic antibiotic is controversial, but still for systemic antibiotics in these cases. And when the patient comes with cataract, it's not an urgent indication, but when the anterior capsule is ruptured or if the patient's media is very poor where we have to do a VR surgery, then we have to go for the cataract surgery. And what are the indications for vitrectomy? A retained intraocular foreign body, a retinal detachment, and of course, the most important thing is dermatitis. If these things are present, we have to go for a vitrectomy. Otherwise, you just repair the open globe injury, wait for some time, and we can go for the rest later on. So there are other possibilities in these cases. You can have kissing choroidals, that is a suprachoroidal hemorrhage. Especially if there is kissing choroidals, it's better to drain. Actually, this is one of the case of trauma. You can find the superior cornea is very nicely sutured. Actually, it's again a superior suprachoroidal, either cannulated or non-cannulated, you can see. So we drained through the same port by raising the intraocular pressure. And these are the days when I was not doing the 2-stage. So most of the blood was drained, then you go for the with the suprachoroidal hemorrhage. And suprachoroidal hemorrhage, usually they do well, whether it's post-surgical or post-trauma. If the fundus is fine, I mean the retina is fine, the patient's outcome is usually good. And starting a retinal detachment in these open globe injury is very difficult. This is a case of a child with a road traffic accident. This is the only eye with some perception of light. And the suturing was done elsewhere. This is how we started off with. We thought nothing in this case, but still want to give a chance actually. Taken under the anesthesia after cutting the membranes in the anterior segment. When we went inside, there was a totally closed funnel RD, the RD which we encountered. But this was done actually meticulously. The patient began the vision of just 1/6. For that child, that 1/6 or 2/6 is important for the care of them. So as I said, even if there is a maximum injury, give a chance for the eye to be repaired actually. And don't ever forget the fellow eye, because there is always a chance of sympathetic ophthalmia. Usually if the patients are young, they come with the difficulty in reading. Actually, the near vision is the first one to get knocked off. Look up ophthalmia, and nowadays with what you call the steroid and other therapy, sympathetic is not difficult. Counseling is very important in these patients, because you should do in groups, because you can call the parents or some relatives. And we have to be a bit brutal in telling the fact, because don't give a false hope. And we have to tell about the need for multiple surgery, and we have to be very frank about the prognosis. And if not last but least, if not least, you have to tell about the thysical. Next one is the rectal foreign body. 18% of the post segment trauma you have what do you call intraocular foreign body. 40% of almost all the open globe injury will have some form of what do you call foreign body inside the eye. And usually most of these patients are within the age of 40, and almost close to 90% are men actually, active working age group. And almost 80% happens because of the hammering of the chisel and hammer, and most commonly it's metallic and magnetic that makes our life very what do you call comfortable. And the risks associated with foreign body are infection, attachment, and necrosis. And the foreign body can be either inert or reactive. So usually the copper and the iron are very reactive. Copper especially causes like an acute endophthalmitis infection. Inert are usually glass, gold, and porcelain. Especially glass, if it is there, many times we go and remove it. No need to remove a glass foreign body if it is inert actually, because when you are removing the glass foreign body, there's a chance of collateral damage. So better to leave the foreign body somewhere at the periphery, and we can go ahead. Same with the stone also. And if a metallic foreign body, most of them are magnetic. So if they are magnetic, it is very difficult for us to manage. The non-metallic will be stone or foreign. And most of them, cornea, and sclera is 20%. 10% will have more than one foreign body. And this we have already discussed actually. The most important thing is analyzing the foreign body, taking the history. So one of the key was a hypodermic broken needle inserted in the left eye of the patient. When I saw, I thought this must be a what do you call a self-inflicted injury. This is a previous X-ray which the patient had, and he came to us. I think somebody's microphone is on. If they can switch off, I think. Okay. So when the repeat X-ray was done, you can see more than 67 degrees. The man was himself by inside. The reason was getting depressed, not getting mad. This is the 3D image of this patient. So history is very, very important whenever you are coming across a foreign body. So this is foreign body of the patient. We could very few. The one in the orbit and over the facial area, they have not been actually. When you come, next coming to the localization, the most important thing is direct visualization. As soon as the patient comes to you, before the vitreous hemorrhage covers the what we call the fundus view, highlight the patient and exactly locate the foreign body. That is very useful. And X-ray, as we have discussed earlier, is most important. Almost 40 to 60% of the foreign body can be detected. Usually the glass is not detected because it depends on the barium content, the lead content of the glass. Okay, but the problem with X-ray is precise localization is not possible. So this is the PA view. We can find the foreign body in the right eye. So we can use a radio opaque marker. Previously it was done, now not done anymore because we have got CT scan or MRI to locate for the exact. So this is the limbal ring. So the limbal ring should be straight in the lateral view. You have to create an eyeball using the ring, and you can find out whether the foreign body is inside the ring or intraocular or extraocular, and you can find whether it within the coat or outside the coat also. This is a patient who came with the history of injury after he was hitting a baldus, that is the ball bearings baldus. It has entered the eye. When we did a PAV, you can find there is a foreign body in the eye, but exact precise localization is not possible. So we went in for what you call limbal ring. In the limbal ring, you can find that the foreign body was outside the eyeball. So we went in for CT scan. Believe me, this foreign body was, after penetrating the optic nerve, was situated in the frontal lobe of the eye. So we just left it. So precise localization is always needed before you take the patient. Ultrasound is a very non-invasive, a simple, non-expensive thing, very highly sensitive. The most important advantage is the associated collateral damages like the vitreous hemorrhage, the retinal detachment, choroidal detachment, or the hemorrhage, or the lens cap status, everything can be assessed with ultrasound, so that it will make us prepare for the surgery well when we are going inside. But the disadvantage is expulsion of the contents. The other one is going to be the CT scan. So it's quite a very sensitive CT scan. Even if the volume is 0.06 cubic millimeter, 100% of the, 65% of the foreign body can be detected. If it's more than that, almost 100% can be detected, but you have to ask for a very closer cuts in these cases. And this is quite precise and sensitive. But in case if it is going to be your, non-metallic like plastics or other thing, you go for a MRI. But before doing MRI, rule out a metallic foreign body, because if it is in the suprachoroidal space, it can move up to 7 to 8 millimeter, the foreign body, when they are doing the MRI, or it can move up to 10 millimeters in the vitreous cavity. So there will be huge collateral damage. So it is useful for wood or plastic, but the disadvantage is it cannot visualize the bone. And if the patient comes in the last window, as I was telling, the patient can come with the symptoms of cirrhosis. You can find the metallic thing and the pupil dilated, unmedicated. You can go for the ERG. It will show reduced B wave amplitude. An important thing about the ERG is if the patient comes with an extinguished ERG, still it is not a contraindication for removing the foreign body. If the patient comes with the extinguished ERG with the foreign body, go for EOG. If the EOG's Ardence ratio is normal, still it is better to go for foreign body removal. Only in the presence of extinguished ERG and the reduced Ardence ratio, there is no point in intervening. So if the patient has got a extinguished ERG and a normal EOG, still you go for the removal of foreign body. This is one of our article, which is actually, in fact, the second largest series of cirrhosis published by us. And most of these cases did well after removing the foreign body. So these are the management objectives, which has been already discussed. So when to time the foreign body surgery? When the foreign body is reactive. All the foreign bodies which are reactive has to be removed. If it is inert, can be left. But if the inert foreign body is causing mechanical damage, you have to remove, and the location, the nature of the foreign body matters, and the type of the foreign body also matters. So these are the routes of removal. Usually we don't now go through the posterior route unless otherwise indicated. So this is the definition of armamentarium. So usually it is defined in the dictionary as a collection of resources available or utilized for undertaking or an activity. So basically why I put this thing is, when it is not like the regular vitreous surgery. You need certain extra instruments when you are going to deal with. So these are the varied foreign bodies which we have removed in our place. You can find this is the connector of a chain from the needle to the wooden piece to thorn, everything. I'll just show you a few videos before going to the methods of removal. This case actually came with foreign body. We have done an ultrasound. We thought it is in the courts of the eye. So there was a collateral damage, that is the vitreous hemorrhage is there. After removing the vitreous cavity hemorrhage, now I can see the fundus is fine. PFCL was injected there was a peripheral detachment. You can find the exit wound. I just completely searched, but I could not find the foreign body. So I thought, okay, the foreign body should be outside the pores. So we just bridled the muscle, okay, because the X-ray was showing it was in the infranasal quadrant. I was telling about the armamentarium. So here what we used was the rare earth magnet actually. So I just was blindly, after bridling the muscle, blindly taking my, what do you call, the rare earth magnet. You can find out. This is a rare earth magnet. And just I was swiping across the sclera. It has come out of the sclera and that it was, lying the subcutaneous space. You can find the foreign body. And the rest of the surgery was done like a vitreous cavity hemorrhage actually. And this is another case actually. This is a metallic foreign body. Usually we don't have much problem in removing the metallic foreign body if the size is less. So here you can find the lenses also clear. So fortunately it has gone outside. And you can find there is a nice metallic foreign body already causing the reaction. There is metallosis around the foreign body. And usually I tease it with NVR blade, 23 gauge NVR blade. But in this case, it's fortunate that it came out. Either you can use a separate port, or I usually use the same port. And then I go for a separate port after removing the foreign body. You extend it. And this is a rare earth magnet again we are using. Okay, so the most important thing is the long axis of the foreign body should be what you call perpendicular to your limbus, so that when you are bringing it out, it should be easy for us to remove. Otherwise, if it is parallel, it will get stuck on the sclera. Will be having difficulty in removing. So long axis can be, should be perpendicular to the limbus. So if the metal is like this, it's very easy. But we will have different foreign bodies in our eyes actually. This is a case where the patient gives history of injury with the thorn. You can find after the vitrectomy, fortunately this patient didn't have any endophthalmitis like picture, only vitreous hemorrhage. You can find actually this is a thorn actually, which is protruding into the vitreous cavity. So we need a special, the instrument. A good forceps, diamond dusted forceps after completely removing everything. So I entered a separate, port through which we use we have made the patient aphakic. You can remove, actually the foreign body was removed and removed through the anterior segment using a mid-persons. And there were some remnants of the ports of the thorn left inside, which was subsequently removed. And we get some interesting cases. This is another case where you could find that after a complete vitrectomy, I couldn't locate the foreign body. If you're not able to locate the foreign body, go for fluid air exchange. Usually the pars plana foreign body, it's very difficult. Actually, they'll be lying somewhere in the foreign body in the pars plana under the fluid, air. The visualization of the foreign body is quite easier. So here you can find out after teasing it out, it was in the inferior pars plana. Okay. So now actually teased out with the rare earth magnet and then it was removed. And this is another foreign body where after doing the lensectomy and doing the vitreous surgery, we had a nice surprise actually. I think it is like some Burj Khalifa tower sitting on the optic nerve head. We have to remove, but there is chance of bleeding, but we have no other option. So we use the same diamond dusted double pronged foreign body forceps, because you cannot remove this foreign body through the scleral wound. You have to make you have to sacrifice the lens. Usually these foreign bodies are removed with a 20 gauge instrument. 23 or 25 are totally useless. You can find out on pulling a large foreign body coming out from the disc with some detachment, which was managed later. So you can remove it through the anterior segment. Yes. So this was the foreign body which was stuck on the disc. So we get a varied foreign bodies. So the reason why I was showing these foreign bodies, we have to have a good armamentarium. This is a rare earth magnet which comes with the 3 interchangeable tips depending upon the scleral port we can use. This is another foreign body thing. This one was developed by Dr. Manish Bapai. Actually, this is the inspiration of Darmia's basket. You can slit out inside the vitreous cavity, then this is very useful for irregular foreign bodies like glass, or what you call the rounded foreign body like ball bearings balls actually. And this is the electromagnet which we have, probably the oldest electromagnet, I think so, on Earth, which is still functioning, more than 45 years old. We don't get this anymore. This is not for the direct removal, but when we get the foreign body to the sclera, then we use this magnet to remove it. Actually, this is quite powerful. You can find actually when you activate, it just takes anything. When you activate just like that, actually quite powerful actually it is. And the tip alone is autoclaved and sterilized. So I think for want of time, I'll skip other foreign bodies. So this is one of the child who was playing with this chain. When she was rotating the chain, one of the, what do you call, the connector went and hit the father's eye. Actually, this is the patient's eye. Actually, this was done quite long time back. You can find out a lot of vitreous hemorrhage, and because of the copper content in this brass, we can find some metallosis. This is the connector. So in this patient actually finally didn't do well. We couldn't restore the vision, but at least we could restore the chain of the child, actually, which she could use it later on. So prophylactic buckle is controversial in these cases. Usually we nowadays don't use, but prophylactic antibiotic, as I have discussed earlier, is important. So whenever there is a foreign body, it depends on the size and composition, but be frank in telling the prognosis to the patient, and the trauma scale is very helpful in telling them the prognosis, and need for the multiple surgeries has to be explained to the patient. Usually the non-metallic, non-magnetic foreign body have a very bad prognosis because it is very difficult in extracting, and the surface also will be irregular. And if the foreign body lies in the anti-segment, usually it is good actually. So the multiple surgeries makes this prognosis bad. Usually it is better to refer a case to the patient was, to a person who can deal it in the first sitting only. Lens damage usually worsens the prognosis due to poor visibility, and the lens-induced complication and rehabilitation also be difficult in these cases because we go for scleral fixation much later in these cases. So I think with that, I'll conclude this talk on the intraocular foreign body, and thank you, TNOA, for giving me this opportunity. Thank you.
Thank you, sir, for that beautiful and lively presentation. We got to see a lot of beautiful foreign body removals. Any comments from the panelists?
Actually enlightened all this, and I am really learned this one. I feel ashamed myself that how we removed foreign bodies in those days, giant magnet in those days. But of course, with that also we had 25% had somewhat good results in intraocular foreign body. And now the modern advancement, you've done wonderful work, and very happy that you done. I got you. Congratulations. Thank you, Dr. Naresh.
Thank you, sir. Thank you, sir. Sir,
for the very informative videos. We learned a lot from you.
Thank you very much. Sir, actually, the things have changed, sir. Previously, we had only contact system. Now we have got non-contact viewing system, which makes our life much, much easier, actually, when we are especially dealing with the globe injuries. Thanks, Deepak. Thank you.
Thank you, sir. Okay, we can now move on to the next session. I would like to invite Dr. Jayanti Peter. Dr. Jayanti did her undergraduation from Madras Medical College and her post-graduation from Joseph Eye Hospital and CMC Vellore. She has also trained at the Queen Elizabeth Hospital in South Australia. She is at present the Associate Professor in the Department of Ophthalmology, Christian Medical College, Vellore. She is an active oculoplastic and cataract surgeon and specializes in lid and orbital surgeries. She has presented various scientific papers and posters in international conferences, and also a recipient of the Best Paper Award in the TNOA conference in 2009, and also Best Paper Award in the Indian Rheumatology Association conference in 2009. She has more than 20 academic publications, and today I would like to invite Dr. Jayanti to talk about orbital trauma, imaging, and management. Over to Dr. Jayanti. Ma'am, we are not able to hear you. We can see your slide, but we are not able to hear you.
Can you hear me now, Deepak?
Yes, ma'am. Yes, ma'am. You're audible. I can only see your that multiple slide in one page. Can you go on to the slideshow?
Yes, going now. Yeah, can you see the?
Not yet, ma'am.
Okay, I'll stop and reshare again.
Yes.
Can you see now?
Yes, ma'am. I have the epidemiology slide.
Okay, fine.
Yeah, it's moving. Yes, ma'am. Over to you, ma'am.
Okay, thank you. As we all know that the polytrauma, among the polytrauma, 61% of the all injuries have some orbital component as well. They have not only vision threatening complications, they have associated brain injuries as well. And in trauma in children, they have periorbital injuries, which can lead to life-threatening as well as vision-threatening complications. The commonest orbital injuries are among young males, and assault is a common cause. And in individuals over than or greater than 50 years of age, falls are the most common cause of orbital trauma. The orbit is a very unique structure. It in that which it is formed by 7 bones, and it forms a compartment which acts like a closed one, and it is directed towards the apex, and the apex of the orbit where the optic nerve enters is only 5 centimeters from the rim. It has a very rich blood supply, including the ethmoidal arteries, which are very prone to hemorrhage, and the orbit is angulated superiorly and towards medially, and it has very important structures like brain and sinuses very close to it. So the mechanism of orbital injuries are mostly due to the hydraulic and the buckling theory, where any blunt trauma will increase the intra-orbital pressure, and that will lead to one of the walls to give way and causing the contents of the orbit to prolapse into the adjacent structures. Just dealing with the different case scenarios, we had a 19-year-old male who's a college student, came to the emergency department with multiple fractures all over the face, and he presented with the left-sided face, which was degloved and avulsed, and the globe was totally distorted. And this was actually the imaging features of this individual. As you can see in this image, he had multiple foreign bodies which were all over the orbit and on the face, and you can see that all 4 walls of the orbit was damaged. And this is the axial view, which shows the multiple foreign bodies, and the globe is totally distorted. And the yellow arrow that you can see shows that the face has been degloved, and that's part of the face which has been degloved. So this is a post-operative picture where we have tried to restore all the walls, which caused the major disfigurement of this individual, and he's been rehabilitated. Unfortunately, you can see the remnant of the eyes, which has been left behind for an ocular implant to be put. Case 2 is a 43-year-old male who came just a few weeks ago. He had a fall from his bike, and when he fell over, the ground had multiple tree branches around. So he had one of those branches poking onto the eye, and he came to the emergency department with a foreign body sticking out of the medial canthus. So it was a big twig, which is about 4 centimeters, and was removed. And we thought that there was no other damage, but because of the presence of the big foreign body, which is removed immediately after the lid tear was sutured, the patient was referred for a CT scan. This is a sagittal CT which we wanted to take to rule out any intra-orbital or intraocular foreign bodies. If you can see that there is a red arrow which is pointing out to a linear lesion which was in between the orbit and the maxillary sinus. So confirming that it was only an organic foreign body and it's not a metallic foreign body, even an MRI has been taken, which didn't actually contribute much. We went back to our image once again to look into the axial cut, and we realized that there was a linear foreign body which was still there on the first post-op day. And this is the bone window, which we did to accentuate the viewing of the foreign body. This is a lung window, which shows the foreign body, which is more prominent now in the axial CT. So we realized that there was a foreign body, which is a twig, which was actually coming from the intraorbital part of the orbit, going into through the maxillary sinus into the pterygopalatine fossa. So we did endoscopic removal of the foreign body. Due to lack of time, I'm not playing the video, and this was a foreign body which is removed. The case 3 was a 1-year-old male who had a fall from about 10 feet. He had nasal bleed and vomiting, and he came with actually a white eye, very mild ecchymosis, only inferiorly. The vision could not be assessed because the child was quite irritable. So on suspicion, because of the ecchymosis, we did a CT scan which shows that there is a small fracture at the posterior end of the inferior orbital wall. This is the coronal view of the inferior orbital wall fracture. A case 4 is a 22-year-old man who has hemophilia, and he was receiving factors on demand. He was an alcoholic, and he was getting into recurrent fights and road traffic accidents. He presented to us with a medial wall fracture with mild ecchymosis, but about a couple of days later, he started bleeding again. So this was the initial axial CT scan, which was done for the patient when the patient came initially with a mild ecchymosis and mild subconjunctival hemorrhage he had. When we suspected a fracture, we actually did a CT scan which shows there is a small fracture of the posterior wall of the posterior part of the medial wall. 2 days later, he suddenly bled again. You can see the orbital bleed actually is making the protrusion of the eyeball making it more prominent, and you can see that there is the eyeball which is actually pushed down compared to the previous CT on my left side. So this CT on my left is actually the CT which is taken before the subperiosteal hemorrhage, and the second one is done after the orbital compartment syndrome, where the whole orbit is full of blood, and you can see the tenting of the globe. The patient has had cantholysis and canthotomy and cantholysis, but unfortunately we could not save the vision of this patient. So we realized that all orbital injuries can present with life-threatening signs as well. Altered sensorium can be a major symptom when the patient comes, and the patient can have neck pain, tingling. Cervical fractures may be associated with orbital fractures. The patient can even present with hemiparesis, ear bleed, nose bleed, CSF rhinorrhea, subconjunctival hemorrhage without borders, which can tell us that there is an intracranial bleed. The vision-threatening signs of these orbital trauma may be an orbital compartment syndrome, where the patient can present with tight lids, with difficulty in opening the lids, a very hard globe, where an emergency canthotomy and cantholysis has to be done. Should not forget the fact that the globe should always be looked for whether there's any perforation or penetrating injury, and intraorbital foreign bodies should always be on a suspicion list. Coming to the eye examination, usually these patients, when they have high impact injuries, are presented in the emergency department setting, and the patients come with difficulty to breathe, and they need first stabilizing before they actually the patients are taken up for any investigations. As Dr. Naresh said in his previous talk, all of these patients should have a medico-legal certificate to be registered, and these patients should have all kinds of formalities to be followed up before the patient can be examined. So these patients are either semi-conscious or in an unconscious state, and they can be very uncooperative either because of their conscious state or because of the altered sensorium. Very brief history taken from either the patient or the relative, and the mode of injury to look to possibly predict what the foreign body could be, and bedside vision assessment if possible. Imaging for imaging CT scan is imaging of choice. We particularly look for fractures and intraorbital foreign bodies, And if the cornea is exposed or if the eye globe is exposed, especially if there is a luxation of the globe, an emergency lid tear, suturing with the protection of the cornea with a lot of ointment to be put on the cornea, as well as an emergency tarsography if the patient's globe is luxated. Coming to eye examination, the patients can present with ecchymosis or panda eyes, extraocular movements to be assessed, proptosis, presence of enophthalmos should be done. And patients who have all these fundus examinations after checking a relative afferent pupillary defect, please do not dilate the fundus before asking the emergency physician, because they may have some neurotrauma which needs pupillary reaction to be assessed to see whether the patient is doing well or not, and assessment of whether the globe is intact or not, to look for any step deformity or infraorbital anesthesia. When the patient is stable, you can look for any any other injuries, and look for best corrected visual acuity to determine the prognosis, anterior and posterior segment evaluation. A force reduction test is mandatory before taking up the patient for surgery if the patient is cooperative. So the imaging of choice is definitely CT scan, and preferably 1 millimeter cuts, and all views, including the axial, sagittal, as well as coronal views indicated, which gives us a matrix of at least 0.5 millimeters to capture all intraorbital foreign bodies which can be detected, and particular provision to be made for the bone and the lung window. MRI is contraindicated, and definitely if there is a foreign body which is metallic, but it's useful when we have ruled out metallic foreign bodies, especially in organic foreign bodies like twigs or piece of a thorn. And these days there are MRIs which are available, which are metal compatible as well. Some people have advised intra-op CT and MRI to see whether the foreign body has been localized, or to reassess about the fixing of the fractures. Navigation systems are not very good for foreign body as such, because they don't pick up very, very small foreign bodies. Most of the traumas in the orbit can be conservatively managed because of extensive edema. There is no emergency if there's no diplopia on primary gaze, or there is no ocular cardiac reflex. They can be treated with ice packs, analgesics, antibiotics, and particularly the patient should be told to avoid blowing of the nose to avoid orbital emphysema. So all foreign bodies have to be removed unless proven otherwise, especially if they're organic, because they can cause severe reaction and infection as well. And particular note to find out where exactly the foreign body is will help us with locating and removing the foreign body. For example, if it's in the sinuses or in the brain, size is very important. If it's very, very minute, it's about less than 0.2 or 0.5 millimeters. If there's metallic inert, we can leave them alone depending upon the proximity of the vital structures. Indications and timing for surgery: immediate surgery, immediately within a few days. Surgeries are advised if the patient has developed severe ocular cardiac reflex and severe enophthalmos and hyperglobus with persistent vomiting. Otherwise, the surgery can wait, and can wait for at least 2 weeks, where the patient's edema settles down nicely, and treated only if there is a positive post-duction test, if the orbital fractures are large, is severe enophthalmos, and if there is diplopia on primary gaze. Children having orbital wall fractures is very tricky, because they tend to have trapdoor fractures where the muscle gets entrapped, and which can lead to hypoxia and necrosis of the muscles. And all children, even with very subtle injuries, if there is a definite history, please rule out ocular cardiac reflex to save the life of the patient. So rehabilitation can be done with biocompatible materials, and we have our experience with porous polyethylene, Medpor, that is with bone titanium mesh, and they all seem to have safe results. So in combination with orbit surgeons, plastics, maxillofacial neurosurgeons in ENT, we can try to rehabilitate the patient. And if there is loss of globe, then in a normal adult, better to put an implant which is not less than 20 millimeters, and especially in a child, the largest possible implant to provide for volume and improve development for proper rehabilitation. So take-home messages, life and vision-threatening complications can happen with orbital traumas. Patients are to be stabilized first to make sure that there are no life-threatening injuries before taking up the patient for any investigation or surgery. And CT scan is the imaging of choice. Foreign body is to be suspected whenever indicated, and most of them can be conservatively managed unless there is an intraorbital foreign body or if there is a fracture which needs to be tackled immediately and repaired only when indicated. Thank you.
Thank you, ma'am, for that wonderful presentation. Any other comments from the panelists? Okay, if there are no comments, we'll move on to our next speaker. Next, I would like to welcome Dr. Subhashini V. She did her undergraduation from Madras Medical College and her DO from RAO, Chennai, and her DNB from Shankar Nethralaya, Chennai. She has also acquired her FRCS from Glasgow. She has received several meritorious awards, including the Dr. S. Gandhimati Nandan Endowment Award for the Best DNB Candidate in Neuro-Ophthalmology. She has also been the runner-up in the E.T. Selvam TNOA quiz. She is at present a consultant ophthalmology at Clarity Eye Care Hospital, Chennai, and also serves as a visiting consultant to several other institutions. She specializes in glaucoma, neuro-ophthalmology, and pediatric ophthalmology. I would like to welcome Dr. Subhashini to talk to us on traumatic optic neuropathy. Over to you, ma'am. Your slides are visible.
Yeah, thank you very much. Good afternoon, everybody. Thank you, TNOA, for the opportunity. And thanks for this wonderful, debatable, controversial topic allocated to me today for discussion. So, about the traumatic optic neuropathy. Sorry, I'm not able to go for the slideshow. Something is wrong, so I prefer to continue this way. Is that okay?
Yes, ma'am. I think few of us have the same problem. Can you please go to the next slide?
You can carry on like this, no problem.
Okay. So, trauma to the optic nerve anywhere along its intraorbital to intracranial course. We all know the intraocular disc is about 1 millimeter in length, and intraorbital is around 20 to 25 millimeter in length, and intracanalicular portion is around 10 millimeter in length, and intracranial segment is 16 millimeter in length. So here, the intracranial portion is bound. The intracranial segment, intracanalicular segment is adhered to the bony canal in a very tight fashion when you compare with the rest of the segments of the optic nerve. So this intracanalicular portion is especially vulnerable for surgery. And the second most common portion of the optic nerve is the intracranial part, which is adjacent to the falciform ligament of the dura. So overall incidence is around 0.7 to 2.5%, and it constitutes around 0.5 to 5% of all closed head trauma and 2.5% of mid-facial trauma. And the most common site of it is the intracanalicular part. The blood supply to the optic nerve, the nerves, and centrifugally by the central retinal artery and centrifugally by the pial plexus derived from the. Am I audible?
Yes, you're audible, ma'am. In between, there was a little glitch. Now you're fine. Please carry on.
Yeah, sorry. And the pial plex.
Right now, we are able to see your incidence slide. You've not gone.
I think my internet was a little slow, I think.
We are able to see your incidence slide.
Central retinal artery.
Yeah, now the first slide is on.
Okay.
Yes, ma'am. Now it's moving. Yeah, now it's moving.
Yeah. So, what are the types of trauma? It can be either direct or indirect. Direct trauma to the optic nerve results from the orbital or cerebral trauma, disrupting the anatomical and functional integrity of the optic nerve fibers. And indirect trauma due to the forces transmitted from a distance, at a distance from the optic nerve. Knowing about the type of trauma helps us in prognosticating the injury. Coming to the anatomical types, this is the optic nerve head avulsion, and the MRI showing the CT scan showing the typical avulsion of the optic nerve from the globe. And anterior traumatic optic neuropathy, wherein the trauma happens proximal to the entry of the central retinal artery, and posterior is the one which is posterior to the entry of the central retinal artery. So posterior is the most commonly at the optic canal, as we discussed earlier. And intracranial trauma causes commonly bilateral hemianopic defects. Direct trauma could be ipsilateral forehead or midfacial trauma due to RTA, falls, or it could be iatrogenic also. Indirect trauma due to orbital hemorrhage, emphysema, and the mechanism is coup and countercoup injury. So how do you evaluate the patient? If you have to suspect a patient with history of trauma and decreased vision, you have to consider traumatic optic neuropathy in your mind. So clinically, as the history for trauma, the type of trauma, the details of the trauma, visual acuity, color vision, RAPD, visual fields, and fundus examination. Fundus examination may show avulsion or disc edema or a normal looking optic nerve. Disc edema in case of anterior or traumatic optic neuropathy with concurrent CRVO or CRAO or ischemia. Diagnostics, the VEP, CT or MRI could be done. The VEP has a diagnostic value in patients who do not remember the time of nerve damage, patients with unreliable pupillary responses, and patients with bilateral traumatic optic neuropathy. The chances of recovery are higher in patients with better responses to VEP. Pattern reversal and flash VEP testing have been used, and it has been reported the patients with a VEP amplitude of 50% or more in the damaged eye have chances for good vision recovery, while patients with absent VEP will not have a good final visual outcome. Regarding the CT, CT is the most commonly used modality for imaging in suspected traumatic optic neuropathy. It's the most accessible imaging method for detecting the optic canal fractures, orbital wall fractures, and the presence of blood in the orbit. It's very helpful in diagnosing direct or indirect TON and can also be used as a guide map for surgical interventions. So it is observed that in patients with indirect traumatic optic neuropathy and posterior orbital fractures, the prognosis is poorer than those with those with direct traumatic optic neuropathy and posterior fractures carry a poorer prognosis than the other indirect trauma and anterior orbital fractures. MRI is not very readily available as CT in trauma settings, but it can be very helpful in evaluating the optic nerve sheath hematoma, optic nerve integrity, and to distinguish between the perisheath hematoma and the intrasheath hematoma. So this image shows the intrasheath hematoma, and this is a CT scan showing the fracture of the lesser wing of sphenoid with a narrowing of the optic canal here. You can compare with the normal canal on the other side. And this is the coronal view showing the same. And here you can see the bony fragment compressing on the optic nerve. And this is very well demonstrated here, the fractured bony fragments compressing on the optic nerve. So the management, the $1,000,000 question is how to manage a traumatic optic neuropathy. Honestly speaking, we still don't have any consensus. So baseline visual acuity, the main role in the prediction of the final visual outcome. So do you give steroids or no steroids? The steroids are hypothesized to reduce the tissue edema, and steroids in high dose have neuroprotective effects through their free radical scavenging properties. In a study, it was found that steroids exacerbated the axonal loss following optic nerve damage in a dose-dependent fashion. A review by one of the investigators of the NASA's study supported the steroids help in neurological salvage when given within 8 hours of spinal cord injury. The limitation of this NASA's is actually it studies the acute spinal cord injury and it is an entirely different part of the central nervous system, whereas optic nerve is just an extension of white matter. So the data extrapolated from NASA's cannot be applicable to the optic nerve. That is the major limitation of the study. So is there any role of surgery and what is the surgery? Optic nerve sheath fenestration and optic canal decompression through transcranial or transethmoidal approach. What are the indications? If there is any intrasheath hematoma, bony fragment compressing on the optic nerve, if there is poor response to initial medical treatment, evidence of optic nerve damage in the preoperative VEP, and lack of evident damage to ocular tissues and intracranial optic nerves. Just the mere presence of optic canal fracture is not an indication for surgical intervention. It has to be the bony fragment which should be demonstrably compressing upon the optic nerve. What are the contraindications? If there is a total or partial optic nerve atrophy, disruption of intracranial segment of the optic nerve, presence of collateral damages like CCF, and unstable general condition. The International Optic Nerve Trauma Study is the largest comparative study analyzing 133 cases of indirect TOA treated with steroids, surgical decompression, and observation. Following adjustment for baseline visual acuity, there were no significant differences between these three groups. Neither the dose nor the timing was associated with a higher probability of visual recovery. The improvement rates reported by other case series for steroid therapy in TON are comparable to IONS, being around 50%. In the traumatic optic neuropathy treatment trial, 120 patients underwent treatment with erythropoietin, methylprednisolone, or observation. Although color vision was reported to improve in the EPO group, improvement of visual acuity was not significantly different between the three groups. And comes the CRASH study, which is the corticosteroid randomization after significant head injury. It's a large randomized controlled trial investigating the effectiveness and safety of steroids in patients with acute traumatic brain injury. These patients were treated with intravenous methylprednisolone, and the initial protocol was to recruit 20,000 participants, but the study was terminated prematurely with the 10,000 odd participants because of detrimental side effects of the steroid arm in the trial. This landmark study provides convincing evidence that steroids should no longer be used in patients with traumatic brain injury, a conclusion that was also reached by a recent Cochrane systematic review. The recommendations from CRASH study must therefore be considered seriously in the subgroup of TON patients who have sustained significant head injuries. So to summarize, baseline visual acuity is the main predictor of the final outcome. Visual recovery and final visual acuity may also be lower in cases with loss of consciousness, lack of visual recovery after 48 hours, absence of visually evoked responses, presence of blood within the posterior ethmoidal cells, age over 40 years, lower grades of RAPD, optic canal fracture, and intraconal hematoma along the optic nerve. Just a few frequently asked questions in a case scenario. A 40-year-old man has sustained a traumatic brain injury in a motor vehicle accident earlier in the day. He is sedated, he is on a ventilator and responsive to verbal commands. CT shows no skull fracture, brain edema, or hemorrhage. He has mild ecchymosis over the left brow and eyelids, and a left APD is there. Otherwise, the eye examination normal. His wife reports that before the accident, he had no eye problems. So we diagnose left-sided traumatic optic neuropathy in this case. What diagnostic tests and treatment do you recommend? He is an unresponsive comatose patient. So the diagnostic test, we can basically check only for the RAPD. Other than that, nothing can be done. And treatment, I would discuss with the patient's attender regarding the option of steroids. If I have seen the patient within 8 hours of the onset of the trauma. And we will also explain to the patient's attender that there is no proven study to show the benefits of steroid in traumatic optic neuropathy management. And if there are no contraindications systemically or neurologically for steroids, then we can try systemic steroids. Would your recommendation differ if the patients were neurologically intact apart from the traumatic optic neuropathy? No, the recommendations don't change. Only the bedside evaluation can be a little more better. What if the patient had imaging evidence of an optic canal fracture? If there is an optic canal fracture with bony fragment impinging onto the optic nerve substance, and we have an experienced endoscopic surgeon or an orbital surgeon to perform the trans or a neurosurgeon to perform a transcranial or a ethmoidal decompression. What if the patient had imaging evidence of hemorrhage within the optic nerve sheath in the orbit? Optic nerve sheath fenestration can be attempted. What if the patient had had documented loss of vision in the affected eye within the previous 24 hours? What if the patient had no useful vision in the other eye? What if the patient is under 20 years of age? Nothing changes. Then the recommendations or the guidelines don't change for all under all these criteria. Given that the Bracken study of steroid treatment of acute spinal cord injury showed that patients began on treatment more than 8 hours after the initial injury actually fared worse than those not treated, would you alter your recommendations if more than 8 hours had elapsed from time of injury to the time of your consultation? I would recommend steroids. So what are the practical considerations here? There are often unavoidable delays in diagnosing TON when patients have life-threatening injuries. If the patient is unconscious for a prolonged period, visual loss is likely to be reported late. And even if a clinical diagnosis is made within the 8-hour window, there are obvious ethical considerations to initiate potentially controversial treatment without proper informed consent. Recent MS studies and the CRASH trial have also highlighted significant gaps in our understanding of CNS injuries, and there is an urgent need for further research into the role of steroids in modulating neuronal recovery following trauma. The logistics required for an adequately powered RCT in TON are daunting, and practically it is unclear whether the resources needed for such a major undertaking are feasible, both in terms of patient recruitment and standardization of the treatment. There is a relatively high rate of spontaneous visual recovery in TON, and there is no convincing evidence that steroids or surgical optic nerve decompression provide any additional benefit over the conservative management alone. Each case, therefore, needs to be assessed on an individual basis, and the patient needs to be made fully aware of both the theoretical risks suggested by the recent studies and the real risk, albeit rare, of a serious adverse event with active intervention. Until better data are available, it is reasonable for clinicians to use their judgment to decide whether to treat an individual patient with high-dose IVMP or optic nerve decompression. Based on the results of NASIS-3, patients who are to be treated with steroids should receive a loading bolus of IVMP 30 mg per kilogram, followed by 5.4 mg per kilogram per hour for 48 hours. If the surgery is thought to be appropriate, the approach should be dictated by the findings on the pre-op CT scanning. High-dose IVMP should be used in conjunction with the surgery. Fractures of the optic nerve are not of themselves indications for surgery, but compression of optic nerve by large fragments of orbital bone should be reduced. Thank you.
Thank you, ma'am, for shedding light on that very controversial topic. Would any of the panelists like to contribute to this topic?
Regarding the optic nerve injury, many of the patients, with the edema is there, they recover very well. Number one. Number two, they also defect a field effect. And recently we have seen a girl patient completely recovered, and vision also recovered, and the field effect also recovered. So these points should be kept in mind. And mild trauma can produce a optic nerve chronic injury. You have seen instead of a mid-facial trauma and all those things. Another point I'd like to stress: any patient comes with a contusion injury. Of course, they are nowadays using 90-day diagnosis, but it's not available everywhere. And everybody should do an indirect ophthalmoscopy thoroughly. You can make out all the retinal dialysis, these are all the other things we can make out. That's what a small information to the younger generation. And ocular trauma is an emergency. Please treat it immediately. If not, you are not able to treat, send them immediately to the concerned centers, tertiary centers. The patients won't come to you unless there's a ocular pain. But recognize them, please send them earlier to the institution where it is done. Never delay the treatment on in trauma. It is really an emergency. Thank you.
Thank you, sir, for your comments. Comments from the other panelists, not just regarding this topic, but regarding any of the previous topics or any general.
Dr. Subhashini? Dr. Subhashini, yes, I just wanted to ask, in your practice, do you give IV methyl prednisolone to the patients, or how do you decide which patients to observe and which patients to start on steroids?
Ma'am, most of the patients come late, present to us very late, unless we see the patient in the neuro ICU with a head injury.
Okay, do you have any cutoff for the visual acuity, or how do you decide?
No, ma'am. If I see a patient with, as sir said, if I see a patient with a disc edema, which means it is an anterior traumatic optic neuropathy, I would explain to the patient the risk and benefit of starting the steroids, and I would prefer to start the steroids.
Okay, is it done at your own setup, or you refer to a multi-specialty? hospital?
Ma'am, if it is an isolated facial trauma with a stable patient with no other instability, instability in the general condition of the patient, then we can very well start with the IVMP with a physician clearance, neurologist clearance. But it's very rare. This setting is very rare. The chance of seeing such a patient is very rare. I've been seeing patients in neuro ICU only or trauma ICU only.
So is there any time frame, like how effective is it? If you start early, is the vision prognosis better, or how long would you how long do you think can methylprednisolone be tried in such patients?
If I see the patient with vasogenic edema, the tissue edema, I would still go ahead with the steroids. There are no contraindications. But if the patient present to us late, sometimes we have been seeing patient more than 15-20 days after the injury, after they get discharged from the ICU. So in those cases, by fourth week or fifth week, this pallor starts to set in. And by sixth week, you will see the optic atrophy. So in those cases, it is not advisable to start any steroids. Mere observation is fine.
Okay. Thank you, Dr. Subhash.
Thank you, ma'am.
Because it's a very controversial topic and you handle it very well. So it's always a discussion with the patient and the family whether to start steroids, especially when they come in early. And yeah, it's always a challenge whether to start or not. But thanks for the presentation.
Thank you, sir.
Okay, very big thank you to all the speakers. Would the panelists like to discuss something else?
Deepak, can you hear me?
Yes, sir.
Thank you. Subhashini, could you stop your slide sharing, please? Deepak, that was my congratulations to all the speakers and especially to you, Deepak, for wonderfully coordinating this webinar. It was an amazing session. Thanks to all the speakers and a special thanks to Dr. Loganathan sir for gracing us with his presence and his useful comments. Deepak, wonderful show. I would let Dr. Nehru do the concluding remarks. Dr. Nehru, are you online?
Yes, yes.
Yes,
good morning to all. Good morning to all.
Good afternoon, sir.
Good morning, Julie King.
I am happy to see that a large audience, especially on Sunday. I remember even 3 years ago, our former director of RAGO, Professor Dr. Loganathan, used to teach us most of the diabetics are being picked up by ophthalmologists, either by 2 ways, whether by looking at a fundus examination or during the routine screening before the cataract surgery. This just goes on to show that the ophthalmologist role is not merely confined to the surrounding of the eyes. Similarly, today, a knowledgeable ophthalmic surgeon, well versed in ocular trauma, will be bound to enter the emergency team, consists of a trauma surgeon, neurosurgeon, and a neurophysician. Today, in these days, the super and micro specialties, one can always refer the case a complex vitreoretinal surgery or laser surgery at leisure to concern specialty. But all ophthalmologists, especially, should have the vital knowledge about the ocular trauma because this area, one area where we don't have the luxurious time. Ocular trauma is a subject where any ophthalmologist, young or old, general ophthalmologist or specialist, fresh or experienced, everyone should have the complete knowledge. I congratulate the organizer for selecting these topics for the today program. I thank the panelists, Dr. Sudarshan Session, Dr. VM Loganathan, Dr. Sujata, and the speaker, Dr. Naresh Babu, Jayanti Peter, Dr. Subhashini, Dr. Anila, Dr. Chandran, Dr. Harni, and the excellent the moderator today, Dr. Deepak, and our TNOA moderator, Dr. Sriram Gopal, and special thanks to our TNOA President Dr. Mohan Rajan, Vice President Dr. Ramakrishnan, President-elect Dr. Ramakrishnan, Vice President Dr. Nirmal, and Secretary Dr. Madhavan, and Treasurer Dr. Loganathan. Thank you all.
Thank you, sir.
Thank you, Deepak. Thank you so much. Wonderful session. Enjoyed it thoroughly. Thank you so much.
Thank you, sir. Thank you to all the speakers. Thank you.
Thank you, Deepak. Thank you all.
Thank you.
Thank you.
Thank you.